Hello, everybody, and welcome back to our B School, Be Better, Be Empowered. I am Dr. Emery Pitcel.
And I'm Rebecca Hall.
Yep, Dr. Emery Pitcel of Rothrock Chiropractic and Rehabilitation, and
Rebecca Hall of Happy Valley Bodyworks
yeah,
Massage Therapy. So
and we're in May of 2025. Can't believe that this is already our ninth installment of this collaborative podcast with Massage Therapy Meets Chiropractic World, where we, highlight some of our differences, but also highlight how much that we complement and collaborate and really work together.
absolutely.
Yeah, for sure. Today we are going into like the front of the shoulder, the front of the chest, a very specific region that's called the pectoralis muscles. Most people don't say pectoralis, though; they just say pecs,
Yep.
right?
Yep. We keep
Yeah,
it short and simple around here.
most definitely. And then because we kind of felt like we couldn't fully tease this out, and it was worth at least mentioning a little bit. There is a bursa, which is just a fluid-filled sac that is actually kind of right underneath like those pec muscles. It's called the subacromial bursa. We'll touch on a little bit of those statistics because that's kind of like tied into this presentation as well too, right?
Yeah, absolutely. Yeah, I'm really excited to get started.
Yeah, me too. So let's just dive right in and start cutting the cake and breaking this all down. So I think the first point to start with would be to say how common is our pectoralis injuries, our pec injuries. The answer is actually incredibly common, right?
Yes.
Um, Anybody that kind of knows the grading of tears, typically tears are graded 1, 2, 3. Like one is like partial, two is like like definitely like more in depth, and then three is like you completely rupture, right? The good news is we typically don't completely rupture like our pec
It's
muscles.
pretty hard to do.
Yes, however, interesting enough, when I was preparing for this podcast, I did find that there are multiple orthopedic journal articles, and some of them actually published on the National Institutes of Health, that say over the last 20, 25 years that the rupture of pec muscles is actually on the rise. Their hypothesis is it's most likely due to the increase of people doing weightlifting.
Hmm.
So we'll get into that a little bit later. I don't want to jump too far ahead, but definitely maybe people trying to go too hard and trying to max out their bench press, and then next thing you know, you got a grade 3 tear, and that's no fun for anybody. But this is an extremely common area for people to at least be carrying undue extra tension and irritation in, and it's
Hmm.
definitely going to sort of like clinically mess with everything else up the chain in the upper back of the neck. Again, more on that to come in the next handful of minutes. And as far as we did mention that subacromial bursa, found statistics that actually say that about 0.5% of all primary care doctor appointments have something to do with either the pec irritation or the subacromial bursitis. So, I mean, not a massive amount, but of all people that go to the doctors and say, I have a musculoskeletal complaint, and they choose to go to their primary, 0.5% is not something to completely ignore. So it's certainly common enough that,
Definitely.
that we feel like we should talk about it, right?
Yeah. Yeah.
Yeah.
Well, and I think just kind of jumping into, some of the causes of pain, right? Like you think about how forward we are as a society, right? We're always on our phones, on our laptops, hunched over our computers, anything like that, right? Everything is so far forward. And I'm sure we'll touch a little bit more on that a little bit later down the road. But also just the fact that we are so far forward and our pecs running across here always get shortened. So when
Yes.
your muscle is shortened, right, it gets really, really tight. And the problem with that is then it can kind of tamp down on anything under, like running underneath it, right? So then we get into, our thoracic outlet syndrome where we're pressing in on nerves or blood vessels, and then you're getting numbness and tingling down your arm and you don't have any
Mhm.
idea why, right? Or you get into, sports side of things with an injury and you're trying to push too much, but you're not doing the same pull motions to equivocate, and get balance in your body. Your pecs are overworked, and then they're, either rupturing, getting injured, you're getting shoulder pain, right? But even that aside, right, you think about just daily life, right? If you're a parent and you're reaching back behind you to hand kids whatever in the back seat or
Uh-huh.
stop them from fighting or whatever, right?
Yes.
As you're doing this motion, that's going to stretch on that. You might overextend it because one kid is yanking on your arm. And same thing, you can have that issue, especially if it's already over tightened. Any kind of overstretch can really cause some issues. So there's a lot of different things that kind of go into it that we'll kind of get more into, but those are just some of the top three things that just come to mind when I'm talking about it.
Yeah, that was a great highlight on cause. As you were going through, it's like I was thinking about like, kind of like what would be kind of like a top five or kind of a quick hit. Certainly, I notice with a lot of musculoskeletal injuries, it's kind of like a bell curve where it's like if you have the right amount of movement, you feel your best. But if you have underactivity, you're not going to feel your greatest. And if you have too much activity, you're not going to feel your greatest either. So you hit the underactivity. That's definitely posture, right? A
Right.
lot of us have very sedentary desk related type jobs where we're sitting here. And again, just nail right on the head, tightened, short, adaptively shortened pec muscles, right? But then on the other side, like you said, definitely like the lifting and those types of athletes. I want to throw under the bus too, like the throwing athletes too, right?
Yes.
I know typically if we're thinking like a baseball pitcher or an outfielder or like somebody throwing like the shot or the discus to try to pick some of our spring sports here, right? Um, that is still we're thinking frequently and talking about like rotator cuff injuries with those types of athletes, but the pec is always a major player in that, and that is
Absolutely.
at least going to be a fractional part of the rehab process to get that athlete back up to speed if they do sustain an injury. Correct?
Definitely.
Yeah, yeah. So jumping in, and I do love that you sort of alluded to thoracic outlet syndrome because that's a good point to say where is the pain at. So with the thoracic outlet syndrome, you do actually have arteries and veins, and you have the main bundle of nerves. It's called the brachial plexus that leaves the cervical spine region, passes through the chest, and then passes, and most of it passes on the front of the shoulder. And with always with like all the spaces kind of in our body, there really isn't that much room for daylight.
Right.
You think that there's kind of all this real estate, but the reality is there is not. And so, like, if you do have that undue, unchecked tension on pec major or especially the pectoralis minor, that could be enough to entrap down that brachial plexus, and then you start to get numbness, tingling, especially what we could see. There could be tingling. Most frequently, we're going to see it in the pinky and like half of the ring finger because it kind of follows like the ulnar nerve distribution. But it can be the entire hand, and usually if it's like more the entire hand, and there could even be like swelling in the hands along with it. That's when we think you don't really have the neurological compression. You have the vascular compression
Right.
style of thoracic outlet syndrome. And that's just the obvious beyond, where's the pain? Obviously, like front of the shoulder too. I know that sounds like duh, but sometimes things don't necessarily hurt where you think they should hurt. And so the whole point of this conversation is to make you realize that like you might be thinking I've got numbness in my hands. And a lot of people might jump to the conclusion of like I've got like a carpal tunnel syndrome or like an compression in my canal of Guillain, but like it really might not be there. It might be right here instead. And so
Yeah.
that's where we got to just do an investigation and do good diagnostics, come up with a good treatment plan, and get people feeling better, right?
Definitely. And I feel like the shoulder is one thing that does a lot of referred pain, right? If you have shoulder issues, a lot of times you're not going to feel it just in the shoulder. So it's a great point that you just kind of bring up. Like, yeah, it could be just all your symptoms are in your fingers or down your arm, or you're like, I don't know why I'm getting this shooting pain into my elbow, but it's actually coming from your pec.
Yeah.
So just super important to look wholly at the body and not just focus on where the pain is actually occurring.
I agree with that. And then we're talking downstream, but you see upstream too, Rebecca?
Oh yeah. I
Yeah.
mean, yeah, you think about like some of the distribution the other way, right? So it's like if you're getting nerve pain down, right, you can also get neck pain up to where that insertion point in that new nerve root is getting irritated, right? So you can kind of see it on both ends of the spectrum depending on where they're having the pain.
That is true. That is true. We'll get into it a little bit more with assessment, but typically, if there's going to be like a cervical and upper back, upper thoracic, and then into shoulder, typically it's going to be more like the neck radiating down to the shoulder. However, you can get the shoulder radiating back up to the neck. I would say literature-wise and what I see in practice, that's not as common,
Correct.
but it does.
Pretty uncommon, but it does happen.
But it can still happen,
right.
And that's part of what makes your and my job. It makes it challenging at times, but it also makes it fun because I think if every case came in and it was just open shut, this is your neck, let's massage it or let's adjust it, it'd get boring after a while, right?
Exactly.
So thank you guys for keeping things interesting.
Keep us on our toes.
Keep us on our toes, absolutely. So we were already alluding to this, but how about some of the common complaints? Like what are some of like the lost functionalities or activities that get hampered if we've got a problem in the pec and in the chest?
Yeah, so it can be a lot of different things. I think a lot of times, if we're just talking about daily living activities, right?
Mm-hmm.
Kind of any kind of push activity. I went to push a door closed or something like that, where I went like this and I had shoulder pain, right? Anything where you're reaching across your body, or like I said, that reaching back in the car kind of motion, right? Or even to get your
Mm-hmm.
seatbelt to put it on,
Oh
right?
yeah.
Any kind of like motion like that where it's stretching something that might be torn, or just having issues, that can be super painful. We talk about that bursa a little bit, right? Like if that starts to get inflamed and rubbing, any kind of motion like that the pec is going to do, right? So you're going to reach forward, you're going to reach down for something, you're going to reach across, like anything that pinches that bursa can cause some more issues as well. So you think about just like that kind of capacity and how much we move and reach and pull, push things in our daily lives. It can
Yes.
happen literally all the time, right? And if you're constantly doing something that's going to be causing that, right? I'm constantly lifting up my 2-year-old to put her on the changing table, or I'm constantly, lifting boxes at work or coolers or whatever it is that you do,
Mm-hmm.
right? That can cause a lot of irritation chronically over time. But then you have the other side of things, right? Where if you're doing your lifting or your more sports related component, you're throwing, right? It can be chronic and overuse, right? But it can
Mm-hmm.
also be, I'm trying to max out heavier than the guy next to me in the weight room, and I put on 2 45-pound plates too many, and all of a sudden it's like that's just like you get a shooting pain in your shoulder and drop the weights. That can be a real issue as well. So it
Yeah.
kind of goes back and forth a little bit.
Yeah, and that was really comprehensive. I think you covered a lot of bases. The only thing that I think you kind of missed on there, if I may indulge,
Please.
is again, we're going back to like the desk worker and the sedentary. There are times where people will be like, you know what, I'm on there and I'm like, typing on the computer or I'm on my phone, and then like I can feel it's just like tight in my upper back or like tight in the front of the shoulders.
Mm-hmm.
Again, we talked about like it could show up in the fingers, but even removing that from the conversation, people sometimes start to register and they'll come in and they'll tell us right away. It's like, I don't think my posture is the greatest, and I think that's part of the problem.
Right.
And that's kind of like their little cry for help to say like, teach me how I can help myself, which
Mm-hmm.
we're happy to show.
Absolutely.
But like people will register that. So like on the very sedentary, the 9 to 5er that's at the computer all day, like they can sometimes come in and be like, that really hurts.
Mm-hmm.
Love that you mentioned the friction and the rubbing with the subacromial. So like the throwing athlete, or like not even just the athlete, but like you said, like mom that's picking up toddler, somebody that's at work, maybe they work at Target or something and they have to push all the big heavy carts or something like
Right.
that.
Right.
All of that can over recruit the pec and everything too. Also want to mention that another common complaint could be whether it's the bursa or the pec. Sometimes that'll be then the complaint of, I'm a side sleeper and I can't sleep on the side of
Mm-hmm.
involvement. Or if you're really lucky and you get it both at the same time, then it's like, I used to be a side sleeper and now I got to sleep on my back or on my stomach. And now because I'm sleeping on my back, I'm snoring and my wife is angry at me. Like these are stories that we hear, and it's
Mm-hmm.
true. And so like we got to get you feeling better so you could get back to like sleeping, moving, performing activities of daily living the way that you're supposed to, right?
Absolutely.
All right. Do you feel good about jumping into anatomical connections right
Let's do
now?
it.
Was there anything from like those first 4 points that we maybe missed? I feel like we
I think we
glided.
covered a decent amount with that.
I think so too. And I know I already said this, but the reality is a lot of injuries that we see in here. Again, it's the bell curve where it's too little movement is not going to be good. Too much overactivity and movement is going to be a problem too. We got to find for everybody, where's your sweet spot where it's like the right amount of activity to the right amount of stretching to the right amount of relaxation and rest that actually gets you feeling the most ideal. And the challenging part is it's different for every single person, right?
Mm-hmm.
And so it's an investigative process that we have to help you figure out, and you also have to just be honest and very transparent and humble with yourself about like what your current limitations and where you currently are at for performance, right?
Right. Absolutely.
All right. So I know every time we do anatomical connections, I like taking the muscle connections and chains, and then you like doing joints. I'm sorry, but we're going to do it again, if that's all right. Because classically, we see that this gets taught basically, I think, I'm quite convinced that every chiropractic school, every physical therapy program, and every massage therapy program talks about upper cross syndrome because
Mm-hmm.
it is common as dirt. So here's upper cross syndrome. I want you to imagine that there's an X passing through my shoulder here, okay? Or like here. And so we've got a crisscross pattern. So we get muscles that are tight, over recruited, and therefore susceptible to injury because they're overactive. And then we get muscles that are on the other side that have just been shut down because of how much the other muscles are overtaking the load. So the crisscross pattern here is the pec muscle. The pec muscle is one that is frequently just spending all day adaptively shortened. It's tight, it's overfired. And sometimes you think like tight is good because then it's like active, but like you said, then if you go to accidentally quick stretch it too much the other way, because it's kind of been sitting in this high tonic and near tetanus phase, it's really easy to accidentally tweak it and overstretch it because it's just all balled up like that, right?
Right.
So you got the pec in the front here, and then the crisscross pattern is to go up into the neck and start looking at like the upper trapezius, the levator scapula, and the cervical extensors. Then the crisscross of the muscles that are therefore going to be weak, right, are the anterior neck muscles. So think like the deep neck flexors, the ones that actually are supposed to help elevate the ribs and get you to breathe, are the ones that actually help to facilitate you pulling your head back or getting it back like that. And then like the rhomboids and the muscles that are between like the shoulder blades. And that ties in just absolutely perfect to, you said, over pushing, over pulling. Way too much of our world is out in front of us pushing, and we just generally don't have enough activities where we're actually pulling.
Yeah.
So as a result of that, that bias of activity of daily living and performance, tight, tight, weak, weak, right? I know if you're listening to audio only, you're not going to see us see the context that I'm making right there. But so what that ends up then being is we get these really predictable presentations with anatomical connections where, because the pec is kind of tight like that, then we are frequently, even if we get somebody that comes in and complains of like a shoulder and we think like, okay, you really need help with like your pec muscles, we can very reliably predict that like at the very least you need some back of the neck work as well too, because that is just part of that tie-in connection. You can't, I say all the time that even if I just do a little bit of shoulder stuff and we do exercises at the shoulder or do some manual therapy at the shoulder, um, just by proxy of only working on that alone, you pull the upper back and the neck along for the ride. All three of those areas are such a tightly knit functional unit that you can't really do exercise or muscle performance on one and not throw undue influence on the other two areas. And that's fine. That's nothing that anyone has to apologize about. Like, we're built to function holistically. We're not built to function in silos.
Right.
But it's just the reality of that, like, yeah, you pretty much like we have a pretty strong inkling that if we're getting a pec problem, we know that anatomically connection wise, we better be looking at the neck as well too, because we kind of just have to tie that all in to get the holistic treatment to get people to where they ultimately need to be.
Yeah, definitely. And then
Yes.
definitely going along with that, right?
Mhm.
I think about, your shoulder movement and how it can be so impacted by this as well, right? So not
Correct.
only just like passively with like the structure shortening and adaptively, but you think about how to bring your arm just overhead, right? We have an attachment in our pec minor, which is our smaller muscle, the pectoralis muscles, right? Right onto the coracoid process of your scapula, which is like that big bone back here that everybody calls your shoulder blade, okay? So what happens is that when that pec minor gets tight, it can actually pull the scapula forward. And then that actually impacts the ability of our arm to reach all the way overhead, right? So we have something called the scapulohumeral rhythm. It sounds really fancy and really complicated, but all it means is like your scapula has to move in order for your shoulder and your arm to get overhead, right? So your arm has for every 2 degrees of arm motion, you have 1 degree of that scapula motion, right? That's kind of like our normal rhythm. But if that pec minor is kind of clamping that scap down in place, you're going to get this motion where you're going to shrug up to try and get that motion because your scap isn't able to get that freely gliding. So that's another big thing that we look for is if you're like, hey, I can't reach overhead without like doing this and it's super uncomfortable and I'm getting a pinching. That's another thing that we can really like start to see with that. Usually with the more extreme cases of like over adaptation and the chronic, more than I would say your acute injuries for pecs, but can happen a lot with that. It's just like your shoulder motion all of a sudden is horrible and it's because of your pec.
Yeah.
So
I am so glad you brought that up. And as soon as you started talking, it's like, I hope you say all the numbers that I say in here. I don't phrase it as like 2 degrees to 1 degree. I actually say like if you're reaching overhead, if you're reaching out in front, if you're reaching back, 1/3 is supposed to be from that proper translation of that scapula on your ribs, and 2/3 is supposed to be from the actual glenohumeral shoulder joint.
Mm-hmm.
So I love that you brought that up, because that's precisely what I preach in here. Getting a smidge ahead, but that's why generally as part of the neck, upper back, and or shoulder rehab, one of the exercises I'm almost always giving for strengthening and reconditioning and recoordination is wall angels.
Yes.
Because like you basically need to know how to like properly recruit like your serratus muscle, and by recruiting that, that's going to help pull down like the overactivity of the pec minor, get that scapular position where it needs to be, so you actually have proper glide, right?
Absolutely.
That's cool. I love these conversations.
Me too.
I know,
It's great.
getting nerdy now. So jumping a smidge into it, but I think we kind of already were starting to tease some like assessment tools and everything.
Mm-hmm.
Can you take the lead and kind of just say like, patient walks in, you suspect it might be shoulder. What are some of like the assessments to confirm?
Yeah. So first thing that I look at, and we talked about this a little bit earlier, you brought it up about posture,
Yes.
right? The second somebody walks in the door, I'm looking at where are their shoulders. Is one higher than the other? Is one more forward? Are they both super forward, right? Are they hunched, right? Or are they like kind of back, but one seems like shifted, right? What's their arm positioning like? Do they have to hold their arms way out here? Is it way in, right? Like looking at all of those just little minute things that you wouldn't necessarily think about on a daily basis as you walk around in your daily life. But you and I kind of look at that and we're like, okay, you clearly have, this is your dominant shoulder. This causes a lot of issues. And no wonder you're having pain, because this shoulder is far forward and this one is normal, right? Yeah. So those little cues that we kind of look to, that's the first thing I'm doing. Usually when I either have somebody in front of me or I get them on the table, we're going to do some range of motion, right? We're going to look at, can you even get your arm overhead without that shoulder shrug? Are you having to compensate? What about coming out to the side? What kind of causes anything behind your back? Can you move that way, right? Without causing pain or significant issues, right? So kind of looking at that range of motion. I might do some strength testing sometimes, but again, that's more my athletic training wheelhouse than it is massage therapy. So if somebody's coming in for massage therapy, I'm going to probably say range of motion is usually good for me to figure out what muscles are tight, overactive, things that I need to work on. And that's what we're going to kind of hit. If I'm doing more of my clinical side, I'm going to get a little bit more in depth with that evaluative stuff, especially with your special testing and, trying to figure out and narrow it down. But yeah, that's kind of my general assessment. And then I'm sure you have your McKenzie method will come out to play. Yeah,
that's where I was going to go first. But I, once again, fully agree. I mean, no matter what, like the very first part is all we're taking history always at the beginning, and we're listening to you. But while we're listening to you, I will never mention to somebody anything about their posture right away, because like I want to see over the course of a 15 to 20 minute history while we're talking, do you basically put yourself into like posture? And I guess now everyone's going to be super aware of it if they watch this before they come in. I should
probably stand up straighter
but you're right. Like definitely like looking at, I fully agree. Looking at shoulder position, I don't necessarily get too obsessed with one high versus low. I kind of actually go more from like the side profile and look like, is one like rounded in and down versus like that. I actually try to get a little bit more kind of clinical relevancy with that, especially when it comes to like pec muscles, but it's still all important, right? All the same ranges of motion as well too. I actually will typically, if I'm doing a full on and I'm getting baselines before doing the McKenzie assessment. So with McKenzie assessment, we got to get baselines. We got to see what's functionally limited or what sort of things are creating pain and discomfort during, and those serve as our baselines. Then we try a repetitive movement exercise. If it's a shoulder that we could call a derangement, then it's going to have a directional preference. And so the directional preference will become obvious, because then if we do 10, 15 reps of a specific exercise and then all of a sudden those baselines improve, then that's the directional preference. It's pretty straightforward. As much as it's glorified, it's basic at the end of the day.
Yep.
And I usually find, much like you, that just with the shoulder joint, and we can't really talk about pectoralis without talking about the shoulder, but there are 6 degrees of mobility at the shoulder. It is basically one of the most flexible joints in the entire body. You could go forward and backwards, you go side and across, and you can rotate. There's not very many joints that are a ball and socket and give you all 6 degrees of planar movements. As an aside, the hip is also one of those that does that, but the hip doesn't have the same amount of flexibility as the shoulder does. But because it doesn't have the same flexibility, it actually has better stability.
Mm-hmm.
So it's one of those things. Flexibility and stability are inversely proportional. You don't get to have both at the same time, right?
Mm-hmm. As much
So
as we would love it some days.
yes, exactly. So I'll actually find in the assessment that honestly, if I do like the six ranges of motion, so flexion, extension, abduction, adduction, external rotation, internal rotation behind the back, usually that's enough to at least have two or three to jump out as a problem if we have a pec muscle. Much like you, if I want a little bit more data, if I'm still not quite certain, then I'll put the patient down on the table. I'll isolate pec minor with a functional muscle test. I'll isolate pec major with a functional muscle test. Maybe like test the strength of the serratus muscle and just maybe grab two or three muscle tests to be certain that if we do our McKenzie exercise, then we could go back and things should neurologically be turning back on if we're moving the shoulder the right way to offload that pec.
Absolutely.
That is probably the extent of what I want to talk about on assessment there, though.
Okay.
So how the $1,000 question is always, and the thing that everybody cares about the most, right? They're like, all this stuff is interesting, but it's how are you going to get me better, right?
Right.
So, how do you like to, with the massage therapy and the athletic training skill set that you have, how do you like to go to town on the pec muscles to help patients get better?
Yeah, and that's, like you said, the $1,000,000 question, right? Because it really depends, right? It depends on your injury, it depends on the severity, and it depends on what's causing your actual pain, right?
True.
So if we're talking about a patient that comes into me with chronic pain, right? Say that they have an overuse and it's irritated the bursa and it, that pec is really super tight, right? I'm going to probably hit like, those tight muscles, work on that, work through the pec, work through pec minor, because I like to do both, because we always neglect pec minor, and then that's usually the problem child 9 times out of 10,
Right.
at least with what I've seen with some of those chronic injuries, right? But you work through some of that. We might do some active release, active stretching, all of that kind of stuff to kind of work through that component. But on the other hand, you have an acute pec injury. I'm probably, if you're coming into me with an acute pec tear, I'm probably going to tell you, you need to rest, you need to let that thing calm down, then come back and see me, right? And we can do a little bit more. That side, you kind of get like strengthening or stretching, right? Those are kind of like your two components, right? When it comes to that. With an injury like that, an acute injury, I would say strengthening is probably more important to get it back where it needs to be. And then you can kind of add that stretching component afterwards. Yeah. But I don't often do like, if you have an acute tear, we're not going to stretch, right? That doesn't make any sense.
Yeah.
Especially from my side of things. Obviously, you can probably do a little bit differently. But from my side of things, it's like, if you have an acute injury, you probably don't want to come see a massage therapist right away, because it's going to freaking hurt if I'm
that's actually true of chiropractic as well too. Like there's been times where I've actually just referred people back. It's like, start with your primary care, see if they can get you like some anti-inflammatories, muscle relaxers, Medrol dose pack. Yep. Let's take a week to let this cool off, because you're just in that super hot, acute, inflamed. I'd love to be able to help, but the reality is like sometimes you have to move the chemical problem out of the way before you can work on the mechanical problem.
Exactly.
So what you're saying is, you said like, maybe we got things. It's like, no, it's the same thing. And any physical therapist will probably tell you the same truthful thing too. If it's too inflamed, you got to let that cool off. Then we can go to work.
Right. And we often, like, when we want to fix something, we want to fix it now, right? We forget that rest is such an important part of like the injury process. And sometimes your body just needs to rest from whatever you're doing. But I also understand, if you're at a desk job and you do computer typing all day, you can't necessarily just say, hey, I'm going to take 3 weeks off, boss. Like, you're good with that, right? Like, most people are like, no, you got to keep working, right? So we got to find ways around that. So definitely happy to talk strategies with my clients about like, hey, this is causing you pain. Maybe I don't work on that today, but let's talk through some things about what you can do to set yourself up ergonomically at your desk, or some other things, right? Work on your posture. What are some things I can give you now to just be like, hey, pull your scaps back, right? Work on pulling your scaps back and sit up. Maybe move your computer, like your laptop, down to your lap, like if you can, right? So you can like sit up, or if you have a keyboard that detaches, keep your keyboard on your lap, and then have your screen up here, so you're working on that posture, right? Just like things to kind of help ergonomically before we actually do the actual fix of the problem.
I agree. I agree. And then as far as like the massage therapy techniques, like what are we're gonna have some technique video with this too, but what are some of your favorites then?
Yes. So I love, and you guys will see this a little bit later this month, but I love, love, love a pec minor release. I think it's super important. It doesn't get hit enough. 9 times out of 10, it's the more tight of the two. So if
Mm-hmm.
somebody comes in and they're like, I have pec tightness, and you go to work on their pec major, and it's like the loosest muscle in the body that you've ever felt, like 9 times out of 10, people like who don't realize that there are two muscles here are like, oh no, you're fine. Like it's probably just some like anterior shoulder. They might go to the delt, whatever. But it's like if you just go underneath that and we work on that pec minor, all of a sudden they're like, oh, my range of motion's better. I can lift my shoulder, like my arm over my head again, like all of those things. So that's a huge big one. The other thing that I really, really like working on is getting that, like we talked about the neck,
Yes.
right? Because that upper trap gets super overactive.
Mm.
And when those two get overactive together, it's not a good combo
No, it's not.
because everything else weakens. And actually, the way that our body physiologically works with this is if these are overactive, your weak muscles, it's not that they're just weak, they can't activate.
Correct.
They are literally being inhibited by your overactive muscles. So I can't even work on strength. Like I can do all the rows that I want, but they're not going to activate if my upper trap is taking over because I'm probably going to go like this every time when I'm
Agreed.
rowing. And then I'm just overactivating my overactive muscle.
Mm-hmm.
So I want to, like, I always tell kids or tell patients, like, I'm going to work on here and here, right? We're going to get those loose. Then I'm going to tell you, hey, maybe try doing some of these things. Go to a trainer at the gym, go to a personal trainer, like work on these things yourself, but do some rows, do some deep neck flexion, right? Work on some of those things on your own so that when you come back, these things that we worked on are less tight.
Yeah. No, that's absolutely perfect. And of course, once again, you go first, and then I realize it's like, yeah, that's a lot of the same things that we do.
We have a lot of similarities, a lot of crossover.
But good movement medicine is good movement medicine. That's just the reality of it, right? And you think, there's certainly there's 101 different ways to skin the cats, but a lot of the same principles are just going to be the same principles. So I already alluded to in the assessment, we're going to start with our Mackenzie assessment. If the pec muscle might be the problem and might be where the pain is, but a lot of times if we think of it as possibly being a shoulder derangement and therefore having a directional preference, I generally find, and I think the Mackenzie literature says that 93% of, or maybe 92% of shoulder derangements are going to be one of three major movements, and two of the movements are repetitive shoulder extension and hand behind the back stretching, which I'll demo some of that as well too. But both of those are opening up pec major and pec minor because it's rocking back that coracoid process to basically get some repetitive stretch load off of the pec minor and try to bring that down. Mm-hmm. Absolutely agree with you as well too. Like you have to basically teach patients how to stretch like their upper trap and how to stretch their levator scap. Both of those muscles make insertions and attachments onto the scapula, and we talked about earlier about that scapula being rocked out, and now all of a sudden we're over recruiting the glenohumeral joint to ask out a shoulder movement. That certainly is going to overtax the pec and the pec minor. So that is all just part of the story. We get into there and definitely do like muscle work. I really love and practice pin and stretching. If I think that like it's a little bit more of like athletic and like we've kind of made some progress, then I'll start to do things that are like a little bit more active component, like things like the post isometric relaxations on the shoulders or PIRs. So that way we're working on like firing and getting deeper into stretches at the same time and really get the neurological reset across the shoulder and the pec muscle. The shoulder joint is actually one of those very few regions. I get asked about this frequently where people are like, can you adjust my shoulder? And I say like 95% of the time, I say, no, I don't want to adjust your shoulder. And the reason why is because I find that most patients can get a lot better with the self-exercise and with mobilizing pressures. Mm-hmm. And we already talked about earlier, 6 degrees of mobility. That's amazing and that's awesome. But with all that flexibility, you have a high degree of instability. I personally view it just being too risky to thrust through the shoulder because there's just too many things that can go wrong with how flexible that joint is. Instead, if I know what direction is the key movement, then I'm going to do heavy mobilizations and really work on the muscle and work on that joint flexibility. And the name of the game is that patients get better, not to crack things to stoke my ego, right?
Right.
But with that said, and we did also discuss earlier, right, neck and upper back just being tightly functionally linked with the shoulder and with like the pec and that subacromial bursa. So like a little bit of investment into some neck mobilization or adjustment and upper thoracic is going to just indirectly pay off like the shoulder and the pec muscles. So we kind of just have to work on all of it as a functional bundle.
Definitely.
And then we talked about a little bit though, but like again, when we get into strengthening rehab, amazing exercises are actually getting like the rotator cuff muscle stronger. So things with like the resistance bands, working at rotations here and rotations here. That way, like your teres and your infraspinatus and your supraspinatus are doing shoulder load work instead of just asking your pec to do it all the time. Got to work on the rhomboids, but like you said, you got to shut off that tension before you get into there. That's another reason why I just absolutely love starting with wall angels too, because it really kind of stretches and gets those other muscles that need to start getting used to firing. It gets them going, and you don't really have the ability to quite over recruit your upper trap and your pec when you're doing like a wall angel exercise.
Absolutely.
So we've got a lot of strategies and they all work, but it's being very strategic. You can't just come in and, of course, take a case that comes in and be like, let's do a cookie cutter approach. We still have to always be assessing where are you at, where's your inflammatory process, what can you do, what can't you do, what's your coordination and your skill. And we always put all of that into account when we're thinking, how do we massage you? How do we adjust you? How do we progress your stretches, right?
Absolutely.
Yeah.
Well said.
I think so too. You were really well said as well too. So to take a quick moment to stop patting ourselves on the back here, we want to again remind you that I am Dr. Emery Pitcel. My practice is Rothrock Chiropractic and Rehabilitation right here in State College, proudly serving Center County and in central Pennsylvania.
Yep, and I am Rebecca Hall with Happy Valley Bodyworks, massage therapy, and I also do clinical massage from an athletic training standpoint, also here in State College.
Yeah, and we, if you can't tell, we like to cross collaborate and pick each other's brains and get ideas. I was telling Rebecca before we went on call here that every single time we do this and we talk technique and we talk through the podcast, I learn at least one or two new things, and then I carry them forward with me in practice. So part of the reason why I'm always excited to do these things is because I think it helps to make all of us better practitioners, and that's what we should be striving for.
Definitely.
Yeah. Well, on that note, I think we want to wrap up for our May of 2025 series, closing out episode 9 of the Be School, Be Better, Be Empowered. Thank you so much, everybody, for watching. Stay tuned later this month for technique videos to kind of satiate the teasers that we gave you a little earlier. But for now, we're going to wrap out this episode, and we thank you so much for joining all of us.
Thanks all.
Yeah, like, comment, and subscribe if you can, and take care until next time, everybody.